Let's take a look at bipolar disorder. The term bipolar disorder generally refers to either bipolar 1 or bipolar 2 disorder. Bipolar 1 disorder is a mood disorder characterized by a history of at least one manic episode, but may have been preceded by or followed by hypomanic or major depressive episodes. The DSM-5 defines a manic episode as a distinct period of abnormally and persistently elevated, expansive, or irritable mood that involves symptoms such as grandiosity, decreased need for sleep, flight of ideas, feeling that one's thoughts are racing, pressured speech, increased talkativeness, distractibility, increased goal-directed activities, and high levels of engagement in pleasurable but risky activities, for example, gambling or sex with multiple partners. These symptoms must last for at least 1 week or be severe enough to require hospitalization in order to qualify as a manic episode. Symptoms must also cause a significant impairment in functioning. Environmental stressors have been found to be more instrumental in triggering the first or second episodes of a bipolar 1 disorder than they are in later episodes. Bipolar 1 disorder is characterized diagnostically by the current or most recent mood episode, which can be a manic episode, a hypomanic episode, or major depressive episode. The current or most recent episode is further described according to the severity of symptoms, including mild, moderate, or severe, or according to the course if full criteria for the episode is not met. For example, with psychotic features, in partial remission, in full remission, or unspecified. There are several additional descriptive specifiers, including with anxious distress, also coded as mild, moderate, moderate to severe, and severe, depending on the number of the symptoms listed that are present. With mixed features, when an individual's mood fluctuates rapidly so that he or she meets the diagnostic criteria, for both manic and major depressive episodes for at least 1 week. Individuals with mixed features may be agitated, have difficulty sleeping, demonstrate changes in appetite, and experience psychosis or suicidal ideation. With rapid cycling, presence of 4 or more mood episodes in the previous 12 months that meet the criteria for manic, hypomanic, or major depressive episode. With melancholic features, when there is predominant anhedonia, which is the loss of pleasure in all or almost all activities, and a distinct quality of a depressed mood. With atypical features, which is the presence of mood reactivity and other atypical symptoms, and when these symptoms neither meet diagnostic criteria for with melancholia nor for with catatonia. With mood-congruent psychotic features, this is when the content of the delusions and/or hallucinations is consistent with typical manic themes. With mood-incongruent psychotic features, when the content of delusions and/or hallucinations is inconsistent with the typical themes for that polarity of mood episode, manic or depressive, or the content is a mixture of mood-congruent and mood-incongruent themes. And with catatonia, when catatonia features are present. Catatonia is a state of apparent unresponsiveness to external stimuli in a person who is apparently awake and includes characteristic psychomotor symptoms. With peripartum onset, this describes the onset of mood episodes, whether manic or hypomanic or major depressive, which occurs during pregnancy or in the 4 weeks following delivery. With seasonal pattern, this is characterized by a regular seasonal pattern of at least one type of episode. This specifier is applied to a lifetime pattern of mood disorders. This specifier is applied to a lifetime pattern of mood episodes. Bipolar 2. In order to be diagnosed with bipolar 2 disorder, an individual must have a history of 1 or more major depressive episodes, in addition to at least 1 hypomanic episode. An individual may be diagnosed with bipolar 2 disorder if he or she has ever experienced a manic episode. If an individual with bipolar 2 disorder experiences a manic episode, his or her diagnosis will then be permanently changed to bipolar 1. A hypomanic episode involves expansive, elevated, or irritated mood for at least 4 consecutive days and includes the same symptoms manifested during a manic episode. The difference pertains to symptom severity. Unlike manic episodes, hypomanic episodes do not cause significant impairment in social or occupational functioning, do not require hospitalization, and do not include psychotic features. Increased creativity and productivity, goal-driven behavior, is associated with bipolar disorder, more specifically with hypomania and cyclothymia. Although there is only one diagnostic code for bipolar II disorder, specifiers, similar to those used in bipolar I disorder, are to be noted, describing the characteristics present in the clinical presentation. Specifying the severity of symptoms is also required as mild, moderate, or severe. You must also specify current or most recent episode, hypomanic or depressive symptoms. You've also got to specify if there is anxious distress or mixed features, with rapid cycling, with catatonia, which is associated with depression, with peripartum onset, or with seasonal pattern. You must also specify course, in partial remission or in full remission. Bipolar disorders are highly likely to be cyclical and recurrent and need to be differentiated from cyclothymic disorder. Cyclothymic disorder is a mood disorder featured by chronic fluctuations between periods of hypomanic symptoms and periods of depressive symptoms. A diagnosis of cyclothymic disorder is made only if there is a 2-year period, 1-year period for children, of cyclothymic symptoms without the presence of a major depressive, manic, or hypomanic episodes. The diagnosis cannot be made if the pattern of mood swings is better accounted for by schizoaffective disorder or it is accompanied by a psychotic disorder. In addition, fluctuations in mood must not be substance or medication induced. Cyclothymic disorder is equally common between men and women, but women are more likely than men to seek treatment. Cyclothymic disorder usually begins early in life, during adolescence or early adult life, and is often considered to reflect a predisposition to other mood disorders. There is a 15 to 50% risk that a person diagnosed with cyclothymic disorder will develop a bipolar I or II disorder. Cyclothymic disorder must be distinguished from a mood disorder due to another medical condition, a substance-induced disorder, bipolar I or bipolar II, and borderline personality disorder. Bipolar I disorder with a lifetime prevalence rate of 0.6% is more common than bipolar II disorder, which has a lifetime prevalence rate of approximately 0.3% internationally and 0.8% in the United States. Compared to major depressive disorder, bipolar I and bipolar II disorders typically begin more acutely and have an earlier age of onset, average age approximately age 20, and bipolar disorder rarely develops after age 40. Bipolar I disorder is equally common in men and women, while bipolar II disorder may be more prevalent in women. In both disorders, sex is related to the type and frequency of the episodes. Men tend to experience as many, if not more, manic episodes in bipolar I disorder and hypomanic episodes in bipolar II disorder than major depressive episodes. Women, however, typically experience more major depressive episodes than manic or hypomanic episodes. Women are more likely than men to experience rapid cycling, that is 4 or more major depressive, manic, or hypomanic episodes during a 12-month period in both bipolar I and bipolar II disorders. Bipolar disorder may account for 1/4 of all completed suicides. Completed suicides occur in approximately 10% to 15% of individuals with bipolar I and bipolar II disorder who are not treated. Serious attempts may approach 50%. Suicide is most likely to occur during a major depressive episode or mixed episode of the disorder. Research indicates the greatest risk for suicide is when the individual's depressive symptoms are beginning to lift, as increased energy levels may allow for the planning and carrying out of suicidal acts. Lithium and other mood stabilizers are the preferred method of treatment for bipolar disorder, as they tend to stabilize or at least diminish manic or depressive symptoms, as well as recurrent mood swings. Lithium has the longest track record. In cases where lithium is ineffective or side effects cannot be tolerated, anti-seizure medications such as Tegretol or Depakote may be employed. The anticonvulsant Lamictal may be particularly effective for bipolar depression. Second-generation antipsychotic medication are also approved for bipolar disorder. Antidepressants are generally inappropriate for treating bipolar disorder because they can be capable of triggering a hypomanic or a manic episode, although there may be times when antidepressant medication will be used in combination with a mood stabilizer or even with the use of an antipsychotic medication. Medication compliance is a particular problem in bipolar disorder because some clients may be unwilling to give up the intensely pleasurable states associated with manic episodes. However, successful medication treatment helps to prevent suicide. In addition to psychosocial interventions, for example, cognitive behavioral therapy, psychoeducation, social rhythm therapy may increase medication compliance. The addition of psychosocial interventions like cognitive behavioral therapy, psychoeducation, and social rhythm therapy may increase medication compliance. Psychosocial interventions are also associated with increased mood stability, fewer hospitalizations, and increased personal functioning. Let's practice with a question for bipolar disorder. A manic episode is best differentiated from a hypomanic episode by answer A, the presence of an elevated mood during manic episodes but not during hypomanic episodes. Answer B, an increase in goal-directed activities with manic episodes but not associated with hypomanic episodes. Answer C, the significantly impaired functioning caused by manic episodes but not by hypomanic episodes. Or D, the increased need for sleep with manic episodes but not with hypomanic episodes. The correct answer is answer C, as a manic episode is indexed by the level of impairment that characterized the mood episode. Manic episodes have significant impairment, while hypomanic episodes are less severe and the person may still function rather well. Answer A is incorrect, as an elevated mood can be present in both manic and hypomanic episodes. Answer B is incorrect, as hypomania is characterized by increases in goal-directed activities. And answer D is incorrect, as both manic and hypomanic episodes are characterized with a decreased need for sleep. We invite you to participate in the next chapter of our series on the key term areas affected by the DSM-5. Thanks for joining us.